All right, we're just waiting for a quorum. 1, 2. Hello, Representative Wilson.
Hello, Senator. How are you?
Good, and there's Representative Barlow and Representative Larson. Heck, we got a real party going here. Speaking of party, here's Senator Schuler. Okay, we're just waiting. I guess Jared's the only one we're missing, right?
I didn't see Representative. Oh, yep, Barlow is there.
Okay, John, Elizabeth, why don't you go ahead and start the stream?
Sure, the stream is live and has been going since about 10 minutes ago.
Oh, all right. Okay, good. So we're back. We'll reconvene the Mental Health Subcommittee on Mental Health Substance Abuse. This is a subcommittee of both the Labor Health Committee as well as the Appropriations Committee. Appropriations just deals with money. Substantive issues on mental health and substance abuse would be dealt with by the Labor Health Committee. There's an intersection, a small intersection overlap where, you know, appropriations is looking at cuts, and we want to make sure that we understand before we or the department starts cutting things that we really understand what it is we're doing and what the implications are. And we know there's just going to be less money, so what's been under consideration is prioritization of services through the community mental health centers, and then whether or not people caught up in the justice system that are on probation, parole, or awaiting sentencing or awaiting trial, whether those should be a targeted priority population. So specifically, our topic excludes the in-prison counseling component. So with that, we left off with an overview of the services through the criminal justice system other than in the prison. And with that, I don't think we have Representative Sweeney yet, do we?
No,
Elizabeth?
I do not see him in the waiting room just yet.
All right, well then let's pick up with Mr. Craig, Wyoming Association of Addiction Professionals.
He has been admitted to the meeting, sir.
Good afternoon, Mr. Chairman, members of the subcommittee. My name is Frank Craig. I'm the president of the Wyoming Association of Addiction Professionals, a NADAC affiliate now. In my day job, I am the state director for Gateway Foundation, and we provide one of the institutional services for substance use disorder treatment. I say one, meaning one contract. There's another provider in Casper that does that as well. It's not Gateway. I noted earlier with David DeMora's presentation, he made specifically a mention about co-occurring disorders being significant, and he's correct. But I think in terms of what we're dealing with too in the criminal justice population is recognition of that population as a kind of its own animal, if you will. I did provide a link to an online publication from the National Institute on Drug Abuse about principles of drug abuse treatment for criminal justice populations. It's a pretty easy read and kind of puts some things out there that are pretty easy to understand, but also important to understand. And I'm not going to go through the whole thing, but I'd have some highlights I would like the committee to be aware of in relationship to what's going on with that criminal justice reformation and things that are coming about from the CSG's recommendations. I would point out on page 1 of that publication, under about middle of the page, number 2, it says recovery from drug addiction requires effective treatment followed by management of the problem over time. And within that paragraph, I it's one of the highlights is it talks about multiple episodes of treatment may be required. That's an important thing to understand for anyone this going through treatment for substance use disorder, because it's a chronic illness, and for criminal justice populations even more so. I think sometimes we think because we're providing the treatment and that an inmate or anybody else goes through the treatment that somehow they're cured. But that's not the case, unfortunately, where substance use disorder is concerned, and particularly when you get into the intricacies of treating a criminal justice population. On page number 2, under number 5, talking about tailoring services to fit the needs, we're looking at about the last half of that paragraph talks about, in general, what the drug treatment should look like for addressing some of those kinds of specific issues. And I would point out that because of all of these things that have to be considered, the modified therapeutic community is what makes it a really good modality to be able to do that. And most of the states, 7 of which Gateway are in, doing institutional treatments under contracts like we do in Wyoming, that's the preferred modality for treatment, because it's a 24/7 environment where they're kind of isolated from the rest of the institutional inmates, and for good reason, so that they don't come to class and act a certain way and then go home to their cell and act another way.
Representative Larson, please.
Thank you, Mr. Chairman. Mr. Craig, I want to make sure as we're talking here, what I'm hearing you just referred to is the population within the confines of an institution, one of the corrections institution. Is that correct?
Mr. Chairman, Representative Larson,
Yes.
The program, for example, residentially, the ITU, Intensive Treatment Unit, is the portion that Gateway Foundation provides at Torrington and at the Women's Center in Lusk. And yes, sir, those are isolated dorms, if you will, where the treatment takes place, where the inmates are housed in that dorm, because we don't want them to be defocused or distracted from other things that go on institutionally with other general population housing.
So, Mr. Chairman, I think, and I appreciate that, but I think really what we're trying to focus on is the treatment and the counseling that they would get after they've been discharged from an institution and maybe back in the community, still under the supervision of the Department of Corrections, beyond parole or however that looks, and not being confined or isolated within the institution. And so, I would really be interested to hear what your thoughts are. As I'm not sure what your public comment was going to be, but I would like to see it focused on that component of services provided for mental health and substance abuse for the prison population.
Thank you,
Mr.
Mr.
Chairman.
President.
Yes, Representative, that is true, and this publication actually addresses that a little bit more into it. I was just trying to get a little bit of kind of a background and setting to understand what happens institutionally and why it happens institutionally. Because you're correct, when you're looking at a continuum of care back out into the community, that does become exceedingly important. I've worked in some states where that continuum of care was an extension of the institutional program, and it was set up as such with the Departments of Corrections respectively, so that there was never an interruption when the person left the facility and went back into the community. They actually went into a specific transitional treatment center where the program was continued on. And sometimes we miss that in Wyoming as having a seamless transition from when they leave the institutional correction setting back out into the community. And we talk about the needs, especially in co-occurring, and that's, you can look at that on page 4 of that publication, the top of page 5. And as you're mentioning, when you flip over in that documentation, and I apologize, committee, that I'm not on a video. I'm actually working in the institution today in Torrington, and we do not have the capability for cameras for visual because we're in an institution. It's not allowed.
So Mr. Chairman, if I may.
Please, Representative Larson, please.
Thank you. I think really what we would, in public comment, rather than make a presentation on a document, we're trying to understand your thoughts on the information that's been provided thus far by the Department of Corrections and by the Department of Health on how we proceed moving forward with providing these services to our citizens that have been impacted by Department of Corrections once they leave the institution. And so I'd be interested in understanding, or do you think we're on the right track with what has been presented this morning? We certainly appreciate the reference that you've given us to this article, but I don't know that we have the time or had anticipated you going through a document as a presentation. And Mr. Chairman, you can correct me if you think.
No, Mr. Craig, we're pushing on to 8 minutes, and what we're trying to do, if the agenda is understand an overview of the Justice Reinvestment Project, particularly the role of the healthcare system after these folks have been discharged. CSG gave us their presentation. DOC, DOH gave us an overview of where they are. We're just trying to understand what our scope of services is, but treatment is important for people who deal or in prison, coming out of prison. We get that part. So can you get to the part that's going to help us enhance our understanding of the topic that's on the table? I hope you understand what we're saying. We need to stick to the topic.
Mr. Chairman, yes, I do understand. I was a little confused earlier because other public participants were able to make presentations, but I'll move along for time's sake.
Well, now I tried to move them along too.
Yeah.
And Mr. Chairman, in fairness to that, there is a difference between public comment and the presentation, and we had it listed under public comment, but we as chairman had requested the Department of Corrections and WAMSAC and the Department of Health to make the presentations, which is different than a response to the presentations, which is public comment.
Thank you, Mr. Co-Chair. That's exactly right. All right, carry on, Mr. Craig.
Yes, Mr. Chairman, thank you. When we're talking about getting some consistency, particularly like when we're talking about assessments, and I do want to speak, when Mr. Dimple was talking about an ASI in particular is a tool. It's not the end of all ends that's used to determine certain outcomes and things and recommendations. And with that respect to what the CSG had proposed, the training for clear standards and trainings across the state, and again, I'll draw that back to working with the criminal justice population, because it is a special population. How we're going to see that in terms of what's proposed for subawards and things like that is still going to be a very limited type of training. There's only a certain number of individuals that are going to be allowed to participate in that, and I think that's kind of a disservice for other people who are doing those kinds of assessments for the state and for those that's involved in the criminal justice population. That self-administered assessment, as it looks like we're gravitating to, does concern me with some respect, because in the ASI, which by the way is not a definitive criminal justice population tool. It's really one of the best methods for criminal justice, but there is no such thing as a criminal justice psychosocial. But the standardization for that means if you don't understand that population and all the intricacies that goes along with it, you may be missing the mark. And I've seen that institutionally when we've received assessments through a post-sentence investigation where there may be determinations that there's no diagnosable material or there's no recommendation for treatment, and it kind of makes me scratch my head because I'm looking at the same individual that had been assessed, and I'm looking at their PSI, and they've got multitudes of charges that are drug-related. It could be DWIs, for example. They might have 6 or 7 DWIs in their criminal history, and the ASI assessment says there's nothing diagnosable and there's no recommendation for treatment. That's concerning. And I think it's important to understand that tool is a face-to-face type of structured interview by design. You sit down with the therapist and with the individual. And there's room for significant inconsistencies if you don't have all of the collateral information like was referred to earlier. If you don't have all of those arrest histories or things like that, you can miss a large portion of what's really the greater picture for treatment of that individual. I do understand too in terms of
Representative
how
Wilson.
that.
Excuse me, Mr. Craig. Representative Wilson.
Thank you, Mr. Chairman. So Mr. Craig, just to the to kind of the specifics on this, then I guess are in a perfect world of creating things anew or something, are you saying that given the fact that most of the community mental health center clients, I mean, a large number of them, 50 to 80% or something, seem to be criminally justice related, are you thinking that it would actually be better in the state of Wyoming if we reduced community mental health services, say by 80%, and just let them deal with particular mental illness, and then set up a Department of Corrections branch of community substance abuse programming of providers that are specific to that issue? Are you saying, I mean, would it, all things being available in the world, do you think that is what we really ought to try to do?
Mr. Chairman,
Please.
Representative Wilson, yes, in terms of ideally, and that's coming from, again, some experiences in some how other states structured that complete continuum of care initiated, when they first appear before the judge until they, if they do end up going to prison and then getting out of prison. Those types of treatment facilities are typically contracted to a Department of Corrections, much like a halfway house, if you will, but with a specific focus on the continued treatment. And those could continue residentially, and preferably, if you're looking for the best outcomes in terms of length of stay, research certainly suggests the longer that you're involved in the program, the greater chances that you're not going to recidivate or return to addictive use. Those types of programs could, institutionally run 9 months to a year, and then when you step down into the community, continued transitional treatment could be an additional 90 days. And then you step down again into kind of an outpatient type of service, and that could continue for 6 months, in some cases up to another year and a half. That total continuum, could be 2.5 to 3 years long, but that type of investment has by far the best kinds of outcomes. But certainly, you know, we are limited financially, and we're limited with how we could do that provider-wise.
Representative Larson.
Thank you, Mr. Chairman. And Mr. Craig, I don't know that I fully tracked with the timeline that you had there. So were you, when you said there would be 6 months, I can't remember what the first time frame was, where they would be isolated in a half, or you'd be kind of what you referred to as maybe like a halfway house type scenario. Is that upon release from their sentence, or is that while they are serving their sentence?
Mr. Chairman, Representative Larson, that continuum typically I've seen is a combination. So for example, we target a 6-month to 1 year institutional residential setting to provide the treatment. Conceivably, instead of the person leaving the facility on their own, if we had transitional treatment centers set up, they would actually be transported either by the DOC or by that contracted provider, so that they don't have opportunities to get out and get distracted and abscond. Typically, you see that within the first 24 to 72 hours when somebody leaves a program institutionally and go to the community. That is the most critical time frame, which is why the peer-to-peer movement is really necessary to be able to connect networks from peer specialists institutionally to peer specialists down on the street. But conceivably, no separation in custody, as it were, even though they're transitioning from in the prison to a community transitional treatment center or provider to continue perhaps up to another 90 days where they're in the community, they live at that facility, but they're getting a job, they're starting to report, meet with their community parole officers or agents, getting connected with that treatment, and then step down from there again, where maybe now they're living on their own, but they're still required to do some kind of outpatient services.
Thank you, Mr. Chairman.
So, thank you, Representative Larson. Okay, Mr. Craig, continue, please. We're coming up on 18 minutes.
Thank you, Mr. Chairman. I'll just wrap it up. I know Representative Barlow had asked some things about continuity of the ASIs and how come it is every time you go to another provider you have to get a new ASI. It really doesn't make sense. Unfortunately, that's how it is in that in the addictions world. We have to do it too. And as long I've been doing this since 1998, as long as you're doing treatment wherever I was working at, that's what you did. You get a new client, you do a new ASI. The ASI, as was pointed out by earlier by Mr. Dimple, it's really the ASAM that sets that level of care recommendation to be able to meet the needs. But you're right, you're correct in that observation, Representative Barlow, for the fact that if we had a system where there was a baseline ASI, a very thorough baseline ASI that was a starting point when you're entering into the criminal justice system and have the ability to then move that ASI with the person as they transition throughout the types of services, even if it is coming to prison. Really nothing is changing in the ASI once they've entered the system. They're in an institutional environment. The psych-social history really is not going to change that much. And that would be another way that we could get some kind of continuity and some kind of standardized assessment process. But then you're looking at the ASAM level of care and then what's going on with that individual wherever they may be at that time. That's what would determine the type of treatment, the level of care and intensity, and the types of needs that need to be met. And just kind of FYI, because I heard some mention about lawsuits that are going on. That's typically what that's about. Is an inmate received an assessment and a recommended level of care from an ASAM while they were in the community. Then they're institutionalized, revoked for whatever reason. Typically, revocation is because they popped hot with a UA, they absconded, they didn't report to treatment like they were supposed to in the community, and then they got revoked and they come into the system. They're reassessed. We look at that information as a failure that whatever their recommended level of care may have been didn't work. So logically, that would constitute a higher level of care to meet the need, and that's where these lawsuits have come from. This has impacted their ability to parole out now, because if they're a residential level of care, then they do not have access to that in the community to make parole until they've completed an institutional program.
Thank you.
And with that, I stand for any questions.
Questions for Mr. Craig? If no other member of the committee has one, I've got one that's a quick one. So in these states where they have the model you're talking about, it's a private provider that's providing a continuum of care from inside the prison to outside the prison back into the community. If you know, that private provider in the prison, do they have access to all that information, all the history of the crimes and offenses that prisoner has had, prior ASIs, medical record? Do they have continuing access to that after they're released back into either transitional care or the community?
Mr. Chairman, in terms of access, yes, they do, but it is a pass-along, if you will. So the institutional provider would set up a discharge summary and required information that's set by the Department of Corrections, what they expect to pass along to the community provider or that transitional treatment provider. And in those cases in states, sort of the provider in the community, there could be multiple different types of providers and contractors to the state. It was not like one entity that had all of that service provided.
And so they're able to do that because they're contracted directly with the correctional system.
Mr. Chairman, yes, sir, that is correct. And in most cases, those states have legislated that the Departments of Corrections set their standards and expectations for licensing, for facility licensing, and things that would be deemed necessary to treat this very special type of population.
Okay, thank you. Anything else for Mr. Craig from the panel? All right, thank you, Mr. Craig. Greatly appreciate your help.
Thank you.
Have a great day. So that completes our public comment. I'd ask members of the subcommittee before we move on to the next topic, did you have anything, any comments on what we've heard so far? Any requests of staff or any of the other presenters? Senator Bouchard.
Thank you, Mr. Chairman. I just want to add that, especially to appropriations, that one of the things that's so important here is that when we started looking at some of these models, one of the ones that we noticed right off the bat was Texas actually mothballed 2 prisons because they have been working over a period of 6 years to model this kind of a model that we reduce recidivism, because we don't have, I mean, let's face it, meth usage is one of the biggest problems we see with the criminal aspect, where they're out on the street and they're breaking in a house to support their habits. So that was a real big addition to have that care all the way through. And mothballing 2 prisons in Texas is a really big deal. It was something that you can read the history on how they started doing it six years ago, and they saw the results of it just last year. So anyway, that's it.
Well, Senator Bouchard, I appreciate you bringing that forward. You're on, I don't know if you're on judiciary now, but are you on judiciary now?
No, Mr. Chairman, but that is one of the issues I mean, I have spoke to the chairman over there in the Senate a little bit about this.
Well, when we got down the road on justice reinvestment, and you know, we were ready to, locked and loaded, ready to go. And what's the name of the district attorney from Casper?
Oh, Mr. Chairman, is Mr. Block? Yeah.
Blonigan. You know, Blonigan came and I think Matt Riedel too, and said, you know, you got it all right except for one thing. You don't have the resources on the ground in these communities to pull any of this off. And so this conversation that we're having and that Representative Wilson's having on labor health is timely in how we structure it. So the request I would pass along, if staff could make note of it, and I'd ask for anybody who wants to respond to this, whether it's DOC, DOH, or WAMSAC, what do we need to do in our model to effectively emulate what Representative Wilson was talking about, what Mr. Craig was talking about, that you've got a continuum of care so you don't have Mr. Dimple's people trying to administer treatment to a parolee and they can't obtain his criminal history. You know, that discharge summary that Mr. Craig described, that should be going straight to the community mental health centers. They should have that in their hands before the guy or gal gets back into the community. And so those kind of things, you know, what do we need to do to make sure that the mental health, that they're effectively going to be contracting with these mental health centers, just like we heard the model that Mr. Craig talked about and that Senator Bouchard talked about. So let's find out what we've got to do to effect that, and whether it can be done administratively or whether legislation is required. Okay. Anything else on those topics? Before we leave that, let's see. We have we've had public comment. So next we have Department of Health updates on questions from the first meeting. So we're leaving the topic of the Department of Corrections, mental health, community mental health centers, except as that insofar as that may be touched upon in these updates on questions. And then we'll go into a discussion on where we go from here. So with that, I'm going to turn it over to whom?
Mr. Chairman, that would be Mr. Johansson from the Department of Health, and probably looking at his
all right,
slide presentation on the role of the state.
All right. All these are the questions that are we to those questions yet, Lloyd?
You know, Mr. Chairman, yes. As a matter of fact, as we start talking, I just sit down with my agenda, but as we, oh, here it is. Thank you. As we start talking or listening to Stefan's discussion, I think what this committee needs to do is to say, is to address, does the state have a role in providing mental health services? And if so, what is that role? Is it a safety net like we've done with Life Resource Center and some of the others? Or, but bottom line, do we or do we not have a role in providing mental health? And then the question is our current community mental health system structure adequate? Is it structured the way we need it to, or does it need tweaking, or do we just heard from some other people that would suggest that it would be completely, I think Representative Wilson made a comment that was completely outside the box, but it was probably one that needed to be, that we should say. So do we reduce by 80% the funding to community mental health centers and put it someplace else, or are we comfortable with where we're at and making tweaks to the community mental health centers to provide and adjusting the priority populations? And then with the fiscal challenges that the state has, is it what populations or what conditions do we try to serve in a community mental health service. And I'm just throwing that out there, Mr. Chairman, because I think those are some of the questions that this group needs to come back both to appropriations and to labor and health to help us move forward in a more defined manner in changing statutes and guidance for community mental health in the state. And so that was the only reason I put those in there, was for us to contemplate that at the conclusion of Department of Health, or the conclusion of our meeting today. I think that that should be an assignment that this committee takes back, and then that they would hopefully consider giving you and I some of their thoughts on how they feel that looks.
So that's the memo that we're about to, so Stefan.
So
Have
Stefan,
at
that.
Thank you, Mr. Chairman and Co-Chairman Larson. Two things on my very brief presentation before kick it back to the committee for discussion and any questions. One, on the agenda, you had asked for us to address questions from the previous meeting. I did want to show the committee, we sent a memo on June 30th answering what I hope is the list of those questions that came out of the first meeting with this group. That was sent on June 30th, and I don't have to address them all today, Mr. Chairman. Happy to follow up or provide additional information for anything that might not be clear. But there were, as I recall, six questions that the committee asked the department. And so we have followed up on those in this memo. I will mention the Department of Family Services, I believe, also addressed you directly in a memo, answering some questions that were directed from the last meeting, more in the family services realm, that the Department of Health shouldn't be answering. So hopefully you have that information, Mr. Chairman. Happy to answer any questions or again provide follow-up. But if there are none, I can dive right into just about 4 or 5 final slides on the conversation regarding the role of the state in mental health and substance abuse services.
I'm not seeing any hands, so dive in.
Thank you, Mr. Chairman. So on this broader topic, this morning the committee was discussing, as I mentioned, kind of a microcosm of this discussion around the mental health and substance abuse system and what it should look like in Wyoming, specifically regarding the corrections population. But as we touched on in our last meeting, and again from the department's perspective, this question is, as Representative Larson just alluded to, of what is the role of the state? What should the role of the state be as it pertains to either providing mental health and substance abuse services directly or funding mental health substance abuse services for specific or general access populations? That has ramifications on really everything that a committee like this or the legislature and state policymakers have to grapple with. So answering the role of the state question, it will have legal and statutory implications around updating what the Green Books say. It will most certainly have financial implications, as you all have alluded to today, especially in light of our budget and revenue situation that the state faces currently. And then maybe most importantly, it will drive everything related to answers to the role of the state question, will drive everything related to policy, operations at the state executive branch level, and what performance outcomes we're really shooting for in a system. Again, not to sound like a broken record, but I think these are the fundamental and philosophical questions that when you define what the role of the state is in any system, similar to what the Facilities Task Force did for the State Hospital and the Life Resource Center, it cascades everything from there in terms of legal, financial, and policy decisions. So with that, Mr. Chairman, wanted to provide this example of the Facilities Task Force and how this kind of worked several years ago, actually about 6 years ago when that process started. And the task force grappled with categories of populations that we were able to produce at both populations that were served at the facilities currently at that time, as well as facility populations or potential facility populations that were in other settings across the state, potentially in other programs at nursing facilities. But it was really important for the executive branch and the legislative branch in that joint task force to categorize and kind of collapse into more discernible categories who those populations were, because otherwise the list really becomes unmanageable. So if you'll recall from our previous meeting with this committee, the priority populations, both at the state and the federal level when it comes to mental health substance abuse, there's quite a bit of overlap and not a whole lot of discernible distinctions between, women, pregnant IV drug using women, general, adult population versus veterans. It's very difficult to say, well, what separates a veteran in mental health and substance abuse need from, someone who is not a veteran but might have a similar condition. So again, it really is important from our perspective in dealing with the policy issues around the role of the state to, as best you can, collapse these populations into sort of meaningful and manageable categories. Otherwise, it does become a little bit unwieldy. So really what the Facilities Task Force did, Mr. Chairman, was try to answer the questions from the task force perspective and then provide it as recommendations to the legislature on a few high-level areas. Number one, the first question was, should the state act as a true safety net? And in fact, the answer to that question became through the process of about a year. The task force answered that question that yes, the Department of Health facilities should be a safety net. That was actually defined in statute, which is in Title 25, Chapter 5, that all Department of Health facilities should be safety net facilities, meaning that that level of care is either unable to be provided in the private sector, or the private sector for some populations is unwilling to provide that level of care. And so that's that second bullet point there of was the level of care the task force looked at, were these certain services or levels of care available in communities or the private sector or not? And we helped the Department of Health and the LSO over the course of those years, helped the task force answer those questions so that we could truly determine what a safety net looked like for facility-based care in Wyoming. And so then the subsequent question was, if the answer is yes, then how should the state provide services? So if the state should be a safety net, and it should provide some level, in this case, of facility-based care to a certain subset of populations, and you can port that over to the discussion we're having now. Should the state be a safety net? Should the state provide in some form or fashion mental health and substance abuse care to populations? Then how should it do it? Is it through direct care, essentially, brick and mortar facilities that the state owns and operates, like our, behavioral health facilities that we have? Or is it through funding and reimbursement? So think of, Medicaid developmental disability waivers. We do not treat those populations directly. We provide funding and budgets for those clients to receive services from community providers. And that all resulted, Mr. Chairman, in this kind of either famous or infamous matrix that the task force developed, and ultimately this is what guided a lot of the legislative and policy decisions for the state hospital and the Life Resource Center. Essentially a populations to settings matrix. And so you'll see everything in red or green or blue indicated that for that particular population, the state did have a role. And it was either the state hospital or the Life Resource Center that would provide that level of care. For any box here that's blank, the task force answered the question, answered the policy question, that the state would not provide services for that population. So for example, for your developmentally disabled clients or acquired brain injury clients with exceptionally difficult behaviors, the state will not provide long-term care for that population, because that can be provided in community programs, in waiver programs, et cetera. Similarly, moving down to, for example, what was defined as hard to place, and it was a bit of a compiled definition in statute, but a good example of a hard to place client in a facility setting was a prior sex offender that for liability purposes, a skilled nursing facility or an assisted living facility in the private sector just wouldn't take. The state determined, the task force determined that acute and step down care for that kind of population would not be provided at one of our Department of Health facilities. long-term care and skilled nursing for that hard-to-place client would be provided, and it was determined that the new skilled nursing facility at the Life Resource Center, the WLRC, would meet that role of the state. So again, not a whole lot of lengthy discussion here needed, Mr. Chairman, but I wanted to point out to the committee a previous framework that was worked or that was used between the legislative and executive branch in a task force that was kind of grappling with similar issues that this committee and the Joint Labor Committee have been when it comes to our community mental health and substance abuse system.
Stefan, before you leave that, I had a question. I want to see first if anybody else on that committee had any questions on what he's presented so far. The second line, Title 25, Civil Commitments, Acute Phase, Wyoming State Hospital. I know everybody, I've heard a lot of people in the legislature holding out great hope that the construction of the state hospital is going to save us money on people that are now going to WBI or other facilities. I don't know how that happens. For this reason, let's say there's somebody in Sheridan, they go off their meds, they break down, or decompensate, I guess the word, they go into a psychotic episode, they end up at Sheridan Memorial. You're not seriously going to send them all the way down to Evanston. Why would you do that? I mean, all they need is they just need to get back on their meds and be stabilized. They're in an acute phase, they're Title 25 civil commitment. There's no way you're going to send them down to Evanston. And so I don't know what percentage of the Title 25 population is in acute phase long enough that they're going to send them down to the Wyoming State Hospital. So help me to understand that particular box.
Mr. Chairman, it's a good question. The idea behind the new state hospital project is there will still be Title 25 volume that occurs in the community. So just by nature of the legal structure, when someone enters the Title 25 system, it's really a matter of generally 7 to 10 days before they're actually civilly committed. When they're civilly committed, which is the final stage of the Title 25 legal process, that's really when most often they're committed to the custody of the state hospital. So to your point, in that really acute first phase, the vast majority of Title 25 clients, even today, before the new state hospital opens, don't make it through that entire civil commitment process, if that makes sense. They're emergently detained. Maybe the detention is continued for 10 days. And within that time period, perhaps they stabilize and return to their community. The idea is if the process moves forward where someone is in that final stage of Title 25 civilly committed to the state hospital, the new facility, both by its new physical plant, as well as its new mission to essentially get some long-term care patients out of the facility, partnering with the Life Resource Center, then the idea is that that wait list and that system will become much more efficient because we won't have folks sitting from Sheridan in WBI, in Casper, waiting for admission to the state hospital, if that makes sense.
Okay.
But it doesn't render completely moot that there will still be folks who are going through the Title 25 process in that first 7 to 10 days.
Okay, thank you. That makes sense.
So moving on, Mr. Chairman, just wanted to give the example of the facilities task force as kind of an introductory framework for the conversation that I'd like to queue up with the committee now regarding this larger topic that you all have been tasked with the community mental health and substance abuse system and potentially reforms partially along some of the lines you mentioned, Mr. Chairman, financial issues that are coming, as well as what you mentioned in previous meetings around should we be leveraging more federal funds? Is the system prioritized to certain clients? Should it be priority based? Should it be general access? These are pretty important and difficult questions to answer. Unlike the facilities and the facilities task force, we're talking largely about non-direct care settings here, and especially not state-owned and operated facility-based infrastructure. So again, it's a little bit more difficult than the matrix you saw on the previous slide to categorize all of the populations, but we attempted to do that again for the benefit that I mentioned, that it avoids overlap and allows policymakers to consider these buckets of of populations at the highest level. So over many, many years since I've been here with various committees, including Joint Labor, Joint Appropriations, the Title 25 Task Force, this group, and others, we have essentially categorized into two buckets what this system essentially looks like, and that's community and institutional care. So the community is really, the front and back end of higher levels of care in many settings. To your point, Chairman Kinski, community providers are often where someone might go for services after they're released from a Title 25 hold, but they haven't been committed to the state hospital, as well as, the front end trying to divert from hospitalization, from higher levels of care, folks recidivizing back to the correction system. That really is what we all think about as the community providers role, and not just community mental health centers, but lots of other providers, waiver providers, DFS, social services, et cetera. Then on the institution side, it's really infrastructure, both state-owned and not state-owned, in and out of state to support higher needs individuals or folks that are in crisis, folks that can't be served for that period of time in their communities or with community providers. So think of, the state hospital, psychiatric residential treatment facilities, prisons and jails, the correction system, a variety of institutional levels of care where these various categories of clients often interact with more of an institutional-based service delivery system. So how we've kind of visualized this, Mr. Chairman, for the community mental health and substance abuse discussion is a framework where we would just propose to look at this role of the state question. And you'll see those two buckets, institution and community, on this slide, with just a handful of categories of populations that, again, over the years, in discussions with you all, in discussions with our own staff, we've tried to collapse into some meaningful, but also kind of discernible or intuitive categories of the types of clients that we see going in and out of this system. And so on the institutional side, we have what we call justice-involved adults. And again, there's a lot of different areas or sub definitions, so to speak, of what a justice-involved adult would look like. We also have acute psychiatric adults. So think of your Title 25 clients, as well as in many cases, your Title VII forensically committed clients. Third, your high needs children and families. So we have a lot of individuals, a lot of kids, and I wouldn't say a lot, but we're dealing with it more and more between Department of Health and Department of Family Services, as we discussed in the last meeting, of children and adolescents that seem to have higher needs or need higher levels of care that might not be available in the communities, and we struggle to place them in appropriate settings, both on the Department of Health and Medicaid side, as well as in the Department of Family Services. So we collapse that into, again, a very high level category of a population here. And then finally, Mr. Chairman, on the institutional side, you're dually diagnosed. So intellectually and developmentally disabled clients who also have mental health and substance abuse diagnoses or needs. On the community side, we've carved this up, again, for discussion purposes and for a framework to work in general access, those who have a pay source. So think of kind of lower acuity people in the community who have insurance or can self-pay, but have general access to the mental health and substance abuse system, like our community mental health and substance abuse centers. Similarly, Mr. Chairman, on the general access side, you have folks with an inability to pay or less of an ability to pay. And that's where the sliding scale comes into play at our community mental health centers. But also you do have a cohort of truly indigent clients that don't have a pay source for the services that they might be accessing. And then finally, there's kind of a flow in both directions with all of these groups. We see, folks who might have been a general access client that, in this framework, and again, these are not clinical definitions, these are more for a policy framework, would become high risk. and potentially someone who, as you mentioned, Mr. Chairman, might have an acute crisis and be put into the Title 25 system. And you have this cycle that you see here with hopefully institutional diversions, but maybe not, and maybe you become an institutional client, but then you have institutional discharges, and it kind of works in a circle here within this framework. And these high-risk populations that we put into this bucket would be identified as such, due to an institutional discharge, coming out of the justice system, coming out of the state hospital system, coming out or in the DFS, Department of Family Services system, or a DD client with mental health needs. And that cues up, Mr. Chairman, the final slide that I have on the community and the role of the state. Is when we talk about tweaking this system or reforming this system, prioritizing the system, it really begs the question from a policymaker perspective of, should the state be a safety net for community mental health and substance abuse services? And as Representative Larson put it, if so, what does that mean? If not, if we should be, kind of a general access system where there's brick and mortar facilities, outpatient and residential services, kind of peppered throughout the state that folks can access, kind of a come one, come all, pay on a sliding fee scale, then this exercise probably isn't as relevant or important, and we should continue to maintain and over the years tweak this general access system. But if the answer to the safety net question, is yes, then the questions become, how do we determine who and what would be eligible under a state safety net system for community mental health and substance abuse services? And we typically, when we talk about eligibility, carve that up along two kind of macro dimensions. And one is some sort of identified need. So like I described on the previous slide, is someone coming out of a higher level of care that should be prioritized? Are they coming out of the justice system, a civil or criminal commitment? Do they have some sort of standardized assessment that says that they meet a level of care or a certain diagnosis that would make that client a priority? And then finally, in many insurance and systems, Medicaid, et cetera, you look at resources, at more material eligibility criteria like income or an ability or inability to pay, insurance coverage, et cetera. So again, Mr. Chairman and Co-Chairman Larson, I just wanted to briefly provide this discussion framework for the committee as it relates to this really broad question that I think you've been tasked with, which is, what does a reform to this system look like, both on financial and eligibility means? And we tried to suggest, again, a framework both visually and kind of a policy exercise with those questions to go through if that's where the committee wanted to go. So I'll stop there, Mr. Chairman. I know that was very fast, but happy to answer any questions or kick it over to the committee for a lively debate. Thank you.
Mr. Co-Chair.
Thank you, Mr. Chairman and members of the committee. If we could go to that slide on 13, Stefan. I would almost, if I look at this and we say justice-involved adults or acute psychiatric adult, could almost be combined and say these are people that are involved by the judicial system. They're either going to go to a state hospital or a designated hospital because they're maybe harming themselves or a threat to harm somebody else. They could be somebody that's created that is at harm of hurting somebody else and has been committed and also committed a crime. So now we find them at that as a Title VII forensic psych situation, or somebody that's committed a crime and has substance abuse. So those three areas, is that fair? So that's kind of how the judicial system is involved in the institution.
Mr. Chairman and
No.
Co-Chairman Larson, I think largely, yeah, I don't disagree with that at all. The only reason we separated justice involved from an acute psychiatric adult is not all folks who access psychiatric hospital services are accessing them through the judicial system. So for example,
Very
you
good.
do have privately insured patients or Medicaid patients that get referred to a hospital for psychiatric services, but are not necessarily committed.
Very good. And then can you help me also down on the dual diagnosed, understand a little bit, or help the committee understand a little bit how somebody that's developmentally disabled then can have a mental disease, or how that works, and then how their primary how their primary diagnosis impacts where they go?
Mr. Chairman and Representative Larson, it's a good question. I'll take it kind of in reverse order. So as an example, we do have clients that from time to time are at the state hospital because they've been civilly committed through Title 25, but also have a diagnosis of a developmental disability. It is a bit subjective depending on the provider and depending on the setting when you get into what's the primary diagnosis. What's the cause of this, of the behaviors we're seeing. Some clinicians in those cases will say it's a primary mental health diagnosis, like paranoid schizophrenia, for example, but also another provider might say this is a primary developmental disability that's driving these behaviors. So it's a bit fluid and a bit subjective depending on the providers, but a good example of how we were thinking about that population is exactly what you mentioned, that we have a client that has both diagnoses. Depends on which one would be primary, but a DD diagnosis and a mental health diagnosis at the state hospital. And the new mission of treating that type of clientele who has DD with exceptionally difficult behaviors and maybe mental health needs as well, would be to acutely stabilize them at the state hospital and then have more short-term and intermediate care at the Life Resource Center with more appropriate levels of care there, and then hopefully a community placement, for example, at a DD waiver provider or with a DD waiver provider to try to foster that independence, employment, housing, et cetera, that we certainly want in those home and community-based settings. So that's, again, a population, all of these populations, the reason for the circle here is because they do move in these categories depending on the setting and depending on the individual client. Representative Larson, that's probably not the best answer, but I gave it my best shot. So please let me know if I can provide additional context there. Thank you.
So, Mr. Chairman, I think on this discussion, it's interesting to me as you begin this discussion this morning, Stefan pointed out that the biggest cost to the Department of Health is Medicaid, which includes the ID and DD waiver, the comprehensive and support waivers, mental health and substance abuse, developmental preschools, the state hospital, and WLRC. And I think arguably this slide 13, the top half, would impact 4 of the 5. It wouldn't impact the developmental preschools per se, unless you had an autistic child that they was dealing with. And so as I look at this chart, and then I consider the charge that we have from Management Council, which is to evaluate how we're delivering mental health to the state of Wyoming, and then how can we do that more effectively to reduce recidivism and reduce fiscal impact on the state. It appears to me that then the community in this slide 13, if we can somehow use our community resources to divert or prevent people coming in at the community side from being either going into the institution or returning to the institution, which is a cost back to the state. So you and I sitting here and Jared and Mike as greedy JAC guys, we're looking at the impact on the state, but we also need to consider the needs of the citizens of the state that have these difficult problems. And so I think I would be interested in a conversation, Mr. Chairman, on how if somebody's seeing this differently than I am, I'm sure open to ideas, but it seems to me that we somehow should maybe identify who the community mental health service providers are serving now. Who are these the same populations that should be served? And if not, identify what those populations are. Does that mean that as they come out of the corrections, while still under the direction of corrections, but out of a facility, that's a priority population to ensure that they don't return back into an institution and bring them back into the community? Does this mean that when somebody's titled, that they can intervene and maybe prevent somebody from being titled down to the state hospital and address them at the community level at a much less cost to the state and a much less social impact on the individual, knowing that he didn't have to go to the state hospital? And so I think our task then is to, if I see it correctly, is to make recommendations back to both committees, Department of Labor and Health and the Appropriations Committee, on how we see this mental health system operating. Is it okay if we kind of ask that question to the committee? And if they're seeing it differently, I'm certainly willing to and happy to get back on the right side of the road if I'm on the wrong side.
Representative Wilson. Lloyd, you needed a few more metaphors in there.
Sorry.
Oh,
Thank you, Mr. Chairman. If I can get on my bicycle and ride along the side of Representative Larson on the road, picking up trash as I go or something. I have a couple of questions and then a few things that I want to throw in. I think we're still in the phase of throwing things in necessarily while they swirl around for a bit. The first is picking up on the safety net question. We did see the map this morning about how many counties where there are community mental health centers. And to respect of the private provider that commented as well, I think what we also would like to know is how many counties are there in which the community mental health center is the only provider? Because, it's one thing to be in Natrona or Laramie County, but I would suppose that there are probably some counties, Niobrara, Crook, I don't know where, I'm just throwing things out, where maybe they are the only provider. That would be just one piece of information.
We'll have John and Elizabeth make note of that we need that either from DOH or WAMSAC or both. That's a good question.
Right. So then following on Representative Larson made comment about my throwing out of an outside of the box idea, which my question about separating out and spending most of our effort on the criminal justice was really just gathered to my intention on that question was just to sort of discern what this idea was. But I think one thing that we really have to think of as we go forward is that it's all very well to look at Texas, but they have 60 times our population, and so one of our main problems in any kind of healthcare in Wyoming is we've got fixed costs spread out over not very many clients. And so if you took, say, Paul Dumple's area where he said he had 1,500 clients and you took 80% of them away, you don't have enough mental health clients left to run a shop, really, in the sense. So I think that although that may be having a lot of specialization is probably better and great in places like Texas and California and Colorado, but I'm not sure that will work very well in Wyoming. And so my last thought then from this that I've been taking notes on is I'm wondering whether you know, to take the idea and not forgetting the, you know, we have severe needs that we are hearing in Labor Committee about, you know, children, adults with mental health, you know, schizophrenia, various things like that. We're serious, severe problems. So it's not only about substance abuse and criminal justice, but maybe what we need to add into the contract or the requirements for the community mental health contracts as the safety net, you know, remembering that the private folks are still out there, is some sort of requirement for criminal justice trained provider folks there. And, you know, just as far as to make sure that they're not starting, oh, I'm a mental health center and I also do substance abuse with criminal justice, but to make sure that they have the in-house expertise and really see that as a part of their operation, with the background that those who testified today as to that need, that they have it. But I think we don't need to divide our services in Wyoming into more silos. Perfect as that would perhaps be, I just don't think we have the capacity to make more silos. We just can't. That's all I have to say, Mr. Chairman.
I was with you right up until the silos. So tell me, what do you mean more? Where would we be making more silos? I was with you right up until that you closed.
Well, Mr. Chairman, earlier I had asked Mr. Craig about, you know, in his perception, would it be more ideal if we were, you know, starting from scratch? Maybe we should take 80% of the funding away from community mental health and just set up a structured criminal justice focused substance abuse programming from soup to nuts, so to speak. And that's what I mean by having a second silo, because then what you would really have, I think, would be a criminal justice substance abuse program, and then a separate small lightly funded state safety net program for people with severe mental illness. And that would be two silos rather than the one that we have now. That was just my thinking.
Okay, other members of the committee? Stefan.
Thank you, Mr. Chairman. If I could just, great points and comments and questions from Representative Wilson. I want to frame this slide with a little bit more detail, just to give you a sense of the exercise that we've gone through, kind of modeling the facilities task force. So when it comes to the community mental health and substance abuse system and the providers that we contract with, I would say each one of these 7 categories that you see here might have some involvement in that system. So a community mental health center sees justice involved and treats and provides services to justice involved individuals, to folks who might have gone into or are coming out of the state hospital, to certain adolescents or higher needs families, also to potentially to DD folks. In addition, general access is part of the bedrock of that system. You know, like I said, brick and mortar facilities where folks can come and get services on a sliding fee scale. So I think there's a little bit of everything in the system now. The point of this exercise is you know, we kind of went through this to collapse these populations as if we had a blank slate. You know, there's no policy or financial constraints on the system we want to design. So what are these categories of folks that we think, you know, would be part of a community mental health and substance abuse system? Then, you know, after going through this, and again, this might not be a comprehensive list, I think it captures most of what we as policy folks and policy makers think of when we think of these populations. But then after that exercise, you know, the reality is you have to introduce the financial constraint, right? So if we had $1 trillion in the system, it would be no problem to say, let's build, buy, or fund every one of these populations, including general access for everybody on a sliding fee scale. But we all know that's not the reality, and even less of a reality now as we go through this. So in somewhat of defense of the community system now, I think being asked to do a little bit of everything and achieve those outcomes is a little bit misplaced. And I think some of the, I don't want to say consternation, but a little bit of the tension that we have in the system where it's kind of everything's a priority and therefore everything is less of a priority because the resources are spread so thin. So the exercise, Mr. Chairman, here after collapsing into these categories would be, if you introduced a financial constraint, how would these then rank? What is the role of the state, you know, first? And then if we had another, you know, $100 million, would we provide, you know, additional services or levels of care for, and again, I don't mean to sound like a judgment call here, but folks with lower levels of need. I'm not a clinician and won't speak to that, you know, part of the debate, but that's essentially the point of this exercise, is to capture what the system would look like with a blank slate. Then the next step would be to introduce those financial or policy constraints. But with that definition of the role of the state, if the committee, the legislature, and the executive branch would do that, again, that would inform what that second step looked like in setting up the policy and the financing, or to some of Representative Wilson and Barlow's previous points, what are the legal and policy vehicles to do that? Should we look at, you know, waiver systems? Should we look at additional financing here as opposed to here? But I think those are solutions before we've again defined the problem or the role of the state first. So just wanted to make that, give a little bit of context behind what this chart and what this exercise looks like, Mr. Chairman.
So out of the 900 and some million dollars general fund that goes through Department of Health, we got to find 200 and some plus. So you're working on your cuts. Community mental health centers are working on how they can restructure, how they can save. It's still an unknown to me what proportion of their population, their cost structure is related to what we're calling non-priority populations. Hopefully it's a very large percentage so that the cuts don't completely disable them. I suspect it's perhaps not a very large percentage of their service population. We'll know. Just two quick things. I want to address your chart with a couple of questions, and I want to circle back around to the narrower question we're dealing with today and Chairman Wilson's work to date. So the question I have about this, and I'm going to pick off one that's familiar to me: adult psychiatric, acute. Okay, so it's one thing to say when this let's say this guy, a guy I'm thinking of is a high school classmate of mine, brilliant, but developed schizophrenia. So let's say, speaking hypothetically, he goes to the state hospital and then he's discharged. He's back to the community. He's not acute, but he needs attention, or he enters an acute phase again. Same thing with a lot of the folks from the VA. I mean, they need continuous attention. And so we got to enter them into the Qualis system. And after 28 visits, we got to ask if we can keep seeing this guy who's been mentally ill for 30 years and monitoring his meds and making sure he's staying compliant. But these are people that are not in the acute phase, but they can be there. So where do they fit? Where do they fit, Stefan, in this chart? Because there's a hell of a lot of them that fit into these other categories too. They need to tune up and a little bit of attention, or they go off the rails. Where do they fit in this hierarchy of yours?
Mr. Chairman, brief answer, and I see Representative Larson has his hand up. The idea here, again, in this framework, and this is hypothetical here, would be a client like that who was in an institutional acute psychiatric setting like the state hospital or WBI, would then, if you look at the bottom of the chart here, coming out of there through an institutional discharge would be considered, you know, a high risk population by very nature of what you mentioned. Someone who might not be acute today, but has had a history with an institutional placement like the state hospital, and then would be identified, quote unquote, as a priority population.
So what that means, Stefan, is the Qualis people or whoever you hire to do this work has to be better at what they're doing. Because for a while there, they were taking people who had stabilized and then telling denying visits, saying, well, the guy's stable, you know, he didn't qualify for any more visits, and which is just wrong. And say the guy never went to the state hospital, say he just shows up at the local emergency room periodically needing a tune-up. So I want you to be aware that there's a large, at least my understanding from the mental health folks, is there's a large segment of people that kind of cycle in and out. The only analog I have, Stefan, is oxygen patients. I dealt with them for 13 years. If they stayed on their meds, if they were compliant, they didn't show up at the ER. But if they're non-compliant, the nurses used to call it a tune-up. Oh, he just got back from the hospital for 3 days. He went in for a tune-up. Now he's back home smoking again. So, you know, there's some of these people just need a continuing intervention. Lloyd?
So, Mr. Chairman, I think that you're exactly on track with what I'm thinking. And I agree with Stefan. Is the example you used is not an acute situation, but it certainly is a high-risk population, a high-risk individual. And the goal is to do exactly as you said, is to keep them on their meds, keep them in the community, living on their own. And so it becomes, so then how do we get the community mental health centers to do that? You might consider something like the community-based medical homes, where we provide a per member per month fee for them to monitor and check with these individuals. Are you on your meds? Are you complying with your doctor's appointments? Are you doing all of those things, knowing, as you pointed out with your oxygen scenario, that if they stay on their meds and their oxygen, then they stay out of the hospital. If we can keep them on, if the community mental health centers can focus on these high-risk populations, keep them on their meds, keep them visiting their doctors, or however that works, I think that that goes largely to keeping them out of going into these high-cost areas there. And so I think what we are kind of tasked at doing then is saying, who then, as with this whole discussion, who are the high-risk populations? Is it a pregnant woman or a veteran, or is it by diagnosis of what the individual has? I think that that's a discussion that this group should have and come back. I think it's a worthy discussion, but I think that high-risk population is much more, is far better served by these general fund dollars than general access with the inability to pay. And I know I sound like Cruella de Vil, but I just do. I appreciate that they could be there. Not saying that general access with the inability shouldn't have, but I think that they're a lower priority.
Representative Wilson.
Thank you, Mr. Chairman. And one other thing in here is, I think, and I want to check this with Stefan, because I don't know the numbers on this, but you know, when we pick out veterans, there's a whole nother service for veterans. I mean, not saying that they have everything available, but you know, we've got 2 VA hospitals, we got the VA clinics, there are services for veterans. If you're a pregnant woman, you are of a certain income, you are on Medicaid. The person like you're describing, Chairman Kinski, is not necessarily, when you mentioned Qualis, unless the person has gone through the whole SSI thing and is on Medicare as disabled, and under 65, this person might not be a Medicaid person. They may be a high-risk person with no payer source other than this block grant thing we give to CRMC. That's where I don't know, Stefan, do you have a person between 19 and 64 who has, say, schizophrenia that hampers their ability to work significantly? What percentage of them have actually managed to get themselves onto Medicare and actually have a payer source? Half, maybe?
Mr. Chairman, Representative Wilson, it's a great question. I don't know the exact number, but you're right that, and I'll use the state hospital as an example. For the majority of our adult clients that aren't on disability or don't meet a categorical Medicaid eligibility criteria, they're not on Medicaid. So you have a 40-year-old woman who gets committed to the state hospital. And I think there's a large assumption that coming out, that client would be on Medicaid. But without those categorical criteria, so age, blind, disabled, that would qualify you for Wyoming Medicaid, it's really limited coverage. So I think you're right that in these buckets that you see on the screen here, none of these assume that Medicaid is the financer of services, which again, I can kind of cues up the question of, not to sound like a broken record, but is the role of the state to act as that safety net in lieu of some other, and I won't try to poke this bear too much, but in lieu of Medicaid expansion for a coverage vehicle or a financial vehicle, what's the role of the state, and in this case, the community mental health system, to provide services for a client like that, or to be incentivized to prioritize a client like that. And that leads me to my last point, which is, like I mentioned, I think there's pieces of this in our community mental health system now. And we as the Department of Health, you all as the legislature, have asked our community mental health and substance abuse system to do a little bit of all of this. And I think it's just resources spread very thin from my personal sort of economics bent when Chairman Kinski, to your hypothetical, person coming out of the state hospital, maybe not acute, but has more of a serious mental health condition that might require more frequent services. The community mental health system is paid the same for those services that they are for any other client in the system, as we're kind of garishly describing as a general access population. Again, not really a clinical term, but that's really the point here is if we've asked the community mental health and substance abuse system to do a little bit of everything, including some of these priority populations, as well as general access, I don't think without, hundreds and hundreds of millions of dollars, we should expect great outcomes. And that's what I think set this subcommittee up, is that more and more what we're seeing, whether it's in the criminal justice population, the Title 25 population, the DFS kids and families, we're seeing more and more of those types of patients or residents that slip through the cracks and might not be, appropriate for the staffing and services that our community mental health center have. But again, partly because they're not set up, financed for that type of a population. They're not staffed for that type of a population in many cases, and it is a mixed bag. That's really the point here, is that, again, there's no difference in financing across these populations you see on the top that I think our community mental health centers often do and could, in a greater capacity, wrap around a client like that. But if they're asked to do everything in a resource constrained environment, I think we're going to have our resources spread pretty thin across these populations that are presenting themselves with a bit higher need.
So I think I had sent to the department a question about, for the green box and the yellow box, what's depicted here, what the turnover is, and if those were eliminated from service, if you just cut them all off immediately, what do we think we'd save? If you just said we're not taking on anybody new that doesn't meet the high risk or priority population, how long, look at your turnover and look at how long it would take before that population dwindled down to nothing. And so we're waiting for those questions, but I want to follow up with where you were going. I'm with you. Somebody who is 40 years old and is chronically mentally ill, you call Bender and Bender, you get them signed up on Medicare or Social Security, you get them on SSDI. And after 2 years, they're eligible for Medicare. And once they're on Medicare, then the state buys them into Medi-Medi so that Medicaid covers the copay. I don't understand why I'm frankly just mystified why such a high percentage of our budget for this population is general fund. And maybe the department, Stefan, maybe you answered my question I'd sent some time ago, and I've just lost the memo because I get so damn many memos. But I gave you a listing of the percentage of mental health substance abuse budget covered for each state, and Wyoming was below the middle of the pack. We weren't the lowest, But there were other states that had a much higher percentage. Now, maybe it's just they, unless you qualify, they just don't give you anything. Maybe that's what it is. But I can tell you just from a prior life, and I think this might be where Chairman Wilson was going. There was I lived in Sunnyvale, and there was that hospital. You know, every big community has that hospital where that side of town goes to. It's a Medicaid hospital. And when you walked in to the emergency room entrance, the first thing you saw was a screening office. And if you came in and you had a knife out of your chest, there's a nurse there with a clipboard. Are you a veteran? Do you have Medicaid? What's your income? And they did everything they could to get them signed up for anything. And that relates to, so I don't know how aggressive we are throughout the system, but given everything we've seen about the lack of a continuum of care, we're probably not all that aggressive at it as some other states that have been so resource constrained. So one of the questions I had that the department answered is, do we sign them up for Medicaid when they're in the correctional system? Well, the answer was, well, they're not eligible. Well, no, I know that. But if you're Medicaid eligible and you get arrested and sent to jail, you can't collect on Medicaid, but you can remain enrolled continuously. So other states don't disenroll them when they go into the prison system. In fact, they enroll them. They're not eligible until they come out, but they screen them. So the day that guy's discharged, he's got Medicaid because he's flat broke. He's been in prison for 3 years, so that they have a source of payment for his treatment. So that's a topic that if that's where you were headed, you know, I'd get Mr. Craig back in, or one of these other outfits from other states to our topic today, which is, you know, the continuity of care, mental health, substance abuse for the correction system, and bring in some of these folks from other states and find the contracted providers, how they do it. How do they make sure that they have a continuous source of payment from the time that guy is arrested until he is discharged from his community-based treatment, including while he's in prison? Go ahead, Chairman Wilson, and then Senator Schuler.
So, Mr. Chairman, the thing is that the majority of the states have expanded Medicaid to cover childless adults between 19 and 64. We have not. So unless a person is either a pregnant woman, which doesn't go on forever, or disabled, the average person in the Department of Corrections between 19 and 64 is not eligible and isn't going to be eligible until they turn 65 years old. So we have deliberately chosen to not have those people be eligible for Medicaid. The only way that we can make them eligible for Medicaid is if you have, and because through my translation work, I have translated a lot of applications for people trying to get themselves on the SSI, the disabled list. It takes a lot of paperwork, a lot of case management, years. It takes years to become determined disabled so that you're on Medicare as a 50-year-old or something like that, and then eligible for Medicaid. But that's not very much of our prison population. We may think they're an idiot and a knucklehead, but that doesn't make them disabled by the federal government.
Okay, Senator Schuler, then Representative Olson.
Thank you, Mr. Chairman. Yeah, my question is right on the same track with Representative Wilson. I'm kind of wondering if, because we're not a Medicaid expansion state, I'd like to know, I think there's what, 37 or 36 states that have. I'd like to know about the other states that have not expanded, what they're doing with their Medicaid situations, with their waivers. Is there something creatively that we could be doing that we're not doing because we haven't expanded, which might help us with, you know, I mean, you'd look at our budget is 91% of that budget takes, I mean, the good share of the folks we're dealing here with, I'm assuming, I guess I don't have the data on that, but a lot of those folks, not just the folks in the prisons, but our mental health folks probably, you know, could definitely be in better shape if they had the ability to be on a waiver and not have to go through the whole SSI situation that Representative Wilson was just talking about. So I'm just wondering if we could do some a deep dive into seeing what those other states that have not expanded with Medicaid, maybe they're doing something creative that we could kind of jump on board with. I'm not sure. Thank you.
Representative Olson.
Yeah, thank you, Mr. Chairman. I just wanted to dogpile on this Medicaid expansion concept. Taking a step further what Senator Schuler said, because when we started this meeting, I wrote down something that Representative Barlow said, which was adult mental health waiver. And so the 19,000, approximately 19,000 people that fall within the gap that Chairman Wilson's talking about, the 19 to, what was the age, 65. It seems to me that there's inside of that category something of an opportunity under the adult mental health waiver. And I don't fully understand that. Maybe I know Representative Barlow had mentioned we would probably be diving into that. Maybe this is a good opportunity to expand upon exactly what that opportunity might be in terms of what portion of the population that we are talking about inside the gap could be touched and addressed by this mental health waiver. Because I understand that's Medicaid. So that would also take us away from that whole SSI deep hole that Chairman Wilson is talking about in terms of being cumbersome and getting somebody on that and covered. So I'd like to learn a little bit more about that waiver.
Representative Barlow.
Mr. Chairman, thank you. So in past discussions, previous years, it's always been a tension, and I'll let Mr. Johansson speak to the tension within the Department of Health, the executive branch, was whether to expand Medicaid wholly or to take particular this individual waiver. I think Chairman Wilson had a interesting query, or maybe it was Senator Schuler, about of the states that did not expand Medicaid wholly, how many of them have the adult waiver? Because one would supplant the whole, would supplant the waiver. So of the ones that don't have it expanded, who has a waiver? But as far as what the waiver would bring to us and the eligible populations, et cetera, I think, first of all, that's a design of ours and an application to the CMS. But Mr. Johansson can probably speak to more fluently about the examinations they've done of that. And I would defer any details that he might have. For any details, I defer to him. Thank you, Mr.
Thank you. Before we defer, Representative Barlow, because of your tenure and your longevity, let me ask you this. So let's look at this chart that we've got here. Cross out the green box and the yellow box. And largely everybody up there we're paying for out of general fund, or just a majority of it's coming out of general fund. If nothing else changed in your prior deliberations, if you just regard this whole picture as static, nothing else changes, are you able to shift 50% of the cost of that over to the feds under this adult mental health waiver?
Mr. Chairman, I guess certainly that depends on the demographics of those folks, of the folks that we're serving now. But I do think, first of all, the 50-50, that happens also, well, I should say, generally that is the Medicaid match. So one, if you leverage 50% general fund dollars and you get the other 50 from the feds, even if you pick up 25 to 30% of this population, is that enough to offset the potential cuts, if you will, to funding, which inevitably change the number of services that can be provided? Combine that, the red boxes, with then the reduction or the maybe limitation for the yellow and green to have access to the system, which some of them would have access maybe through this mental health waiver. And I think actually it is something we should be examining, is how do we take those same general fund dollars you were talking about, leverage them for the population that could use them, and what's our value? And like I said, I'm going to let Mr. Johansson speak to see if there's been any analysis of that, because in the past times, there's always been a propensity to push toward Medicaid expansion, not the waiver. Thank you.
Thanks, Eric.
Mr. Chairman, and to address Representative Barlow's good points, briefly, I'll mention that the same process that we would go through with you all to develop and implement a Medicaid mental health waiver would be very similar to what we're proposing for the system as a whole here. You have to answer a few questions for what the waiver would cover, who it would cover. Generally, a Medicaid waiver is a home and community-based alternative to some sort of other level of care. So instead of providing care to someone in a psychiatric hospital, you develop a home and community-based service waiver that would cover mental health services as well as potentially medical, full Medicaid medical benefit for a population. That's essentially what an adult mental health waiver is, what a developmental disability waiver is, what a long-term care waiver is. It's some sort of alternative to another level of care that would be kind of an optional and expanded Medicaid coverage for a certain population that needs to be defined. There has to be criteria in a waiver that you say these people would be eligible, and it's can be condition based, financial, income based, geographically based. There's many different options. So the process that I think we're pushing to go through as a state would be very similar as what we would go through in developing a Medicaid waiver. But in theory, yes, you could cover through a Medicaid waiver a certain type of population that would be paid for with Medicaid funds, which at our match rate would be 50-50, federal funds and general funds. And the question becomes, how do you come up with the state match, with the 50% state match? Do you cut it out of mental health and substance abuse? Do you appropriate it? Do you develop a new tax to have that money? I mean, those are questions that would be on the operational side and probably a bit premature at this point. But Chairman Kinski, the slide that you see in front of you is not a description of the system as it exists today, but a potential framework within which to build what the legislature and what the executive branch would want the system to look like. So who are the populations that the state has a role in either providing services to or providing funding for? And we listed just everything that we think is part of the system today. But again, this exercise is meant to be a blank slate to look at who those populations are, and then you would introduce the policy, reimbursement, and legal vehicles in which to cover them.
Yeah, I didn't hear the waiver saving us a lot of money. It sounded like it was a whole new program that would probably end up being more money, not less, than we're spending now. That's what I take away from that, but I don't know, Lloyd.
Mr. Chairman, I'd like to go back to a comment that you made, make sure that I'm getting this accurate, because we've got the community mental health program as it is funded today, and then we look at the services that you provided, and then you brought in the challenge with Qualis doing an evaluation and for the services provided. And Qualis, for everybody, is one of the contractors that Department of Financial, or the Department of Medicaid and Medicare in the state office uses to evaluate these Medicaid reimbursements. But so my question then to Stefan is, in the community mental health system where we provide this block grant, are the reimbursements, or do the reimbursements to the community mental health centers go through a contractor for evaluation before payment is made?
Mr. Chairman, Co-Chairman Larson, in terms of what you called the block grants. Essentially, the contracts or grants from the state with the community mental health and substance abuse centers. No, there's no prior authorization or utilization management contractor like there is for all behavioral health providers, community mental health centers, and others in the Medicaid program, which is a policy decision. The state contracts, the block grants, as you called them, are carved up along basically 4 different areas: mental health outpatient, mental health residential, substance abuse outpatient, and substance abuse residential. And there's certain contract requirements, namely the amount of service hours that are required to be delivered in the contract period. But it is not set up in a fee-for-service model like Medicaid. It is not, does not go through the same utilization management like prior authorizations or service caps and medical necessity, things like that. It's very different from Medicaid.
And Representative Larson, the issue I was referring to, Qualis, was early on. That's, remember that there was a provider had a situation in Buffalo, and so part of her lament, I verified with the Community Mental Health Center that was an issue. They did get it resolved, but it just, the point being is that you have to take a more nuanced approach than saying they're either acute or they're not acute, and if they're not acute, they're not on service anymore. Was the only point of that. And I think Stefan contemplates in his model that those people are continuously regarded as high-risk populations. So I don't know. So then, Representative Wilson, if we can circle back around to the topic that our objective. So let me tell you how we got here. Is Representative Larson and I were talking about, we thought, because of our exposure on appropriations and his on other committees, that we had a rough idea of the mental health and substance abuse system as it related to the chronically mentally ill and so forth. But the prisons, the correctional system was just unknown to us. And so we didn't know what everybody else's level of knowledge was. So the objective today was to get us up to your level of education. And for myself, I've satisfied that. I don't know everything I need to know, but I know a hell of a lot more than I did. And let me say, I'm in awe of what work you've done with CSG. It's phenomenal. As I was listening, it reminded me you probably had experience somewhere in your work life with whether it's continuous process improvement or quality assurance or QI or Six Sigma. That's all it is there's just all these discontinuities in the continuity of care. And so a lot of those solutions, 80% of your fix just comes from putting together a standardized procedure manual and going out and educating people. And that in itself may resolve quite a bit. And then to that, there's some other things that undoubtedly, besides the legislation you said you've already got drafted, there's some other things that came up here, like, getting contracts in place so that the mental health service providers can actually have access to criminal history and a discharge somebody out of the prison. So there's no doubt there that I mean, in my mind, this population has to be a priority population, and there needs to be some adjustments and tweaks to the system. And it looks to me like you're on the right track with everything that you're doing. Call it phase 1, and then you follow on with a phase 2. Is there anything about your work that you've been doing that did not come out in the CSG presentation today, and what their recommendations roughly were so far that you think might add to the discussion and our understanding?
Mr. Chairman, thank you. First, I would just like to say what you are so kindly calling our work is the work of Department of Health and Department of Corrections and CSG. And frankly, the Labor Committee has had really almost nothing to do with it other than to occasionally provide a forum for presentations and ask questions. But really the agencies and the providers have done, 90% of the work. And then, we managed the House Bill 31 through the floor last year. But I just want to the agencies and the providers are carrying the heavy load. I do want to follow up a little bit on what Senator Schuler said. I do think one of our further requests ought to be to look at the states that have not expanded Medicaid and see if they're using waivers or what they're using to not use general fund. Because if we don't want to go that route, we need to consider that. I think then just following up on our idea a little bit of, yeah, I mean, I think it's really clear that the criminal justice involved population has got to be a high risk area. It's really a challenge. I mean, I don't want to be here just saying, no, you can't cut anything because, hey, I did my 2 years on appropriations. I know that's not a thing, but just as appropriations looks through the whole, through the next 6 months, there are certain areas of our general fund spending, mental health, criminal justice, maybe DFS, child protective services type of areas that if we cut them, it will just kill us in the next 5 years. I mean, it would just kill the state, the communities, everybody around. And so we've just got to be so wise on what those services are for the safety net, not only for the person, but for the community around them. So no, that's really all I had. I was really mainly just struck with making sure that Department of Health and Department of Corrections and the providers got most of the credit. And of course, Representative Barlow was chairman for 2 years before me, so I'm sure it's all his work too.
Well, so I'll take those I'll take those in reverse order. So the direction to John Brody and Elizabeth Martineau would be to, I guess, first to look at the work that's already been done on the waivers. There's no sense reinventing the wheel legislatively. And then what would you suggest that they, to reach out to see what other states have done, checking with NCSL, where else are they going to go for that kind of information?
Mr. Chairman, I think CSG probably also has a good handle on this because they do so much work in this area. They can probably give them a really short summary and not make them have to do too much research.
And so do you want a memo and then possibly put it on consideration for our next meeting or a future meeting?
I think that would be, if we could get it in sort of a matrix, states, how they cover their mental health services for non-Medicaid people, some tips from them, so that, and if we can look at it far enough ahead so that we can really come in and say, okay, this really sounds good.
Okay. And so then as a heads up to John and Elizabeth, you're going to want to ask the same set of questions with respect to adolescents caught up in the justice system, whether it's girls at the girls' school, boys at the boys' school, what do other states do? There's discussion with DFS about converting the girls' school from a correctional facility to a treatment facility. They don't know whether they can do that at the boys' school because they have to keep that, it's tougher cases. They have to keep that correctional status. But so you're going to get the same round of questions when we start talking about adolescent and juveniles caught up in the justice system. So you may as well take a look at what other states do there as long as you're gathering data. Representative Larson, can I finish up with one thing with Sue Wilson? So Sue, I appreciate the accolades that you gave to staff and CSG, and that's important, but there's a great danger this will be a study without a champion, somebody like you in the legislature that says, what do we need to do legislatively to make this happen? What do we need to do as legislative advocates and champions to make sure that this really moves forward? Because Department of Corrections and Department of Health will ultimately hit the same roadblocks that the community mental health centers will. There's a judge who doesn't understand it. There's a county attorney who's never heard of it. There's some probation officers that don't believe in it, and there's just almost a whole evangelization function. And then frankly, there is a legislative role. Like, we believe in decentralization. We believe in local choice. Hey, me too. But should a county sheriff be able to say, I will not participate in 24/7 when it's been proven to reduce recidivism and drunk driving by 40%? Because that's our system now. We let each county sheriff decide whether he's going to participate in that or not. And I don't know, maybe if they're receiving state funds, they should just do it. A single point of entry, for juveniles. That was a mandate. I don't believe in federal mandates much, but that's one that worked. I think that's this one single reason that juvenile crime has fallen by 40 to 50% in the last 15 years is a federal mandate that said, you're going to stop letting these kids drop through the cracks. You're going to have multidisciplinary teams, and you're going to triage them, and you're going to give them the right treatment modality. I think that's what stopped all the juvenile crime in its tracks. It's just everybody getting their crap together and getting in one room and not allowing 6 different parts of the system do whatever the hell they wanted. That takes legislation. So that's my soapbox. Lloyd.
Thank you, Mr. Chairman. And so if I could ask our LSO staff, kind of going along with what Chairman Wilson's questions is, can you help us maybe give a Department of Health and help us figure out how many of our community mental health centers are the only mental health providers in a county? And then if you could, when you're looking at other states and what they do, make sure that you identify for us whether or not that state has expanded Medicaid and whether or not that state has got the adult waiver that we just visited about. And then, Mr. Chairman, I think the other thing that I'd like to see us get ready for is we get this other matrix on what other states are doing. I think it would be also helpful if we could just once again fill in these boxes on the famous slide 13 and say what services are now being provided by the community mental health providers, so that we can determine, maybe look at which of those would absolutely need to be required as a priority, or which ones would maybe be ranked down there. But I think we're going to have to, I think we're going to have to, at some point, if I'm hearing the mental health providers correctly, they're wanting some direction rather than us just coming in and telling them, with less money, please do more. I think they need to have some direction. And we've indicated that perhaps we need to look at restructuring that in a manner that would allow us to incentivize these more difficult populations, and then also maintain populations like the one you referred to on an ongoing basis to keep them from becoming a serious problem again. So that's my request, please.
So Representative Barlow.
Thank you, Mr. Chairman. I'll be very brief. So first I want to point out the CSG work, the justice reinvestment, that was actually was by the Judiciary Committee for several years, and Jared Olson was probably there in the beginning days. Some of that got shifted, as Chairman Wilson noted, to the Health Committee, but most of the work and most of the legislation came out of the Judiciary. The second thing, I guess, is on the county level, to Representative Larson, Co-Chair Larson's question and Chairman Wilson's question about access within a county. I think access within a county a year ago looks sounds a lot different or looks a lot different than it does now with just where we've been with where we are now with telemedicine, and folks having different access. So I think that what we thought a year ago is different than what we might think of access now. The second thing, and give me the thumbs up if I'm coming through okay, Mr. Chairman. Third thing, it'd be
That's how they hang us.
when I listen to our discussion, what I'm struggling with in my own mind is the executive branch is making budgetary changes now. So we are going to respond, and potentially in a special session, but more likely more broadly in a general session, the upcoming general session of the new legislature. We're going to be reactionary to what they did. It's not hand in hand, it's reactionary. And we're going to be trying to either fill gaps, add funding, find alternative funding, etc., or adjust policy, statute that needs to be adjusted. So I guess when we talk about all these different things, I think they have to be boxed into that. Is it reactionary? Is it policy adjustment? Or how are we going to try to respond or to whatever changes have come about? The final thing I'd say is that if there's one gap in Wyoming statute, there is no definition of community mental health and substance abuse and what is expected and where it goes. There's lots about prevention, there's lots about other programs, but as far as mental health and substance abuse, general access or not, it doesn't matter. It's just there's very little said in statute about what the expectations are that we have placed both on our Department of the Executive Branch and subsequently on the providers that they contract with. Thank you, Mr. Chairman.
So Representative Wilson, has your committee looked at legislation that would clarify the expectations in statute, including for the mental health centers along the lines of priority populations only? And if not, do you anticipate you will?
Mr. Chairman, so we have not had any discussion about the priority populations. Certainly discussion of some of the statutory requirements and prevention and that kind of thing is on our original interim topic list. Of course, things have been kind of overtaken by COVID. We only met one day so far this interim, and that was all COVID all the time, just about, maybe not entirely, but I think that I'm in the process of working out our next interim meeting, and that certainly seems like something that can go on our August agenda. I think that would be
okay.
At least something to work with. Who knows? It may change over a year anyway, but at least it would be something that would be there. I think we're probably the place to have that discussion.
Okay, and then I think Representative Larson has his hand up, but I just wanted to follow up on something that Representative Barlow said, Representative Wilson, because he gave kudos to the Judiciary Committee, and that was my first committee assignment after John Schiffer died. And I gradually kind of discerned where he had been heading. The whole CSG Pew thing had kind of died with him. And then gradually we kind of got our legs under us and brought it back. But my whole experience there was, we're 5 years into it, and it could have been a much shorter, except the legislature does its work by committees, right? And so it was kind of a Judiciary Committee thing, and then they said, you know, it's past us now, it's a labor and health thing. But in all that, in the states, and that's what I was hoping these folks would talk about, but they didn't. Originally, they would not come into the state of Wyoming until they knew they had 5 champions: the Chief Justice of the Supreme Court, the Governor, the Attorney General, and the President of the Senate and the Speaker of the House. Because they said there's no point in doing any of this work if those people are not on board. And so it was instructive to me that all 5 of those people signed on to it, but all 5 of those people are gone. And so it's another conversation, Sue, but and maybe you and I'll have it a little bit later if you haven't completely burned yourself out on it today. But I don't know where we've got to get those folks back on board, and it may take some legislative champion. We can cut and cut and cut and study all we want with CSG West, but there's a whole lot of cats in the system that need to be herded. Take a look at, just do a search on the Chief Justice of the Ohio Supreme Court. That was the champion there. She decided they had to do something about their opioid crisis, and she was the pivot point. She called all the players to the table and said, we're going to do something about this. We're going to get it done, as intractable as it is. And it takes somebody in that kind of position to really make a difference and to help drive forward what we hope we can do. So that really is the end of my soapbox, Lloyd. You raised your hand.
I did, and would like to take, just ask there's a couple of things, Mr. Chairman. I think that Representative Barlow is right on in his comments, and I think making some differentiation on whether we're being reactive or is going to depend a little bit on what the executive branch can share with us on these budget reductions, because I think that we could maybe walk in conjunction with these budget cuts that are being done now. As Stefan pointed out, once you understand the populations and the revenue source, it allows you to then make some decisions. And so the more we can get away from being reactive and putting this thing together, I think the better off we'll be. I would argue a bit. I think that the assignment to this committee was to look at the very things that I think we were just trying to hand off to Labor and Health. And I think that we need to be careful about not fulfilling our responsibility of coming up with how this looks moving forward and what the priority populations are. We're the ones that have been having the discussion to this work group, and make sure that we've kind of got that, and then hand that off to both committees. I think that it's an inefficient use of committee time to go back and forth between this work group and the committee on making those decisions.
So before we wrap up, the last thing we want to do, I think, is to get staff to give us back some feedback on what all we've asked of various players. But before we do, I do want to get to this Venn diagram we've been assigned, kind of the intersection of appropriations and mental health and substance abuse, is still an elephant. And as we move forward with our agenda, I just wanted to see get some feedback from members of the committee, and if staff could take notes, what would you like to see us explore next, or somewhere in the process? What are some agenda items you'd like to see? What are some things that you'd like to learn that we haven't explored? Just give me some feedback. I don't want to get too far ahead of the committee. I like to know where the committee would like to go. Any feedback, thoughts, ideas, Jared? Anthony?
Mr. Chairman, I just kind of feel like I'm always coming back to the same place, and free markets actually provide competition, and they provide it causes people to sharpen their knives and their pens and provide better services. As we look at a lot of these things, even in mental health, I know of cases, and I'm not privileged to talk about them right now, but there are cases that we've done the wrong thing. And so we've had a conversation about not having more silos. If we're just going to pick the winners and losers, I think the public is the one that loses.
Okay. Sue, Wendy?
Thank you, Mr. Chairman. I think we've had some really good conversation and some good things that have come up. I would still like to maybe see if there's some way we could maybe streamline our mental health centers just a little bit more. I talked a little bit earlier about seeing if we could do some more collaboration with private or independent sources, because I know that, for instance, if, just take Northern Mental Health, if they have 2 psychologists and an addiction professional, and I don't even know how many professionals they have on board, but if we could maybe collaborate more with some of the folks that might be able to contract and make it cheaper, because, let's say, personnel costs are huge, especially when you add in your, insurance and all your benefits and all of that. So I just wonder if there's any way we could streamline our mental health centers and make them more efficient than what they are now. And I do like the idea of looking into the waivers and seeing what other states are doing that haven't expanded with Medicaid. Those are probably 2 of my priorities. Thank you.
Okay. Representative Wilson, anything?
I'm sorry, Mr. Chairman, I had to step away there for a moment. I had a phone call. So
Just
are you
thoughts?
asking? I don't have any final remarks, I don't think.
No, it was just agenda ideas, things that you'd
Oh.
really like to see us take a look at that we haven't.
I think, and by the way, I was just thinking to say before I stepped away that I am probably going to be meeting with the governor's health policy advisor this week. So maybe get some insight from her. But, I think to Representative Barlow's discussion, in some ways, the agenda may be a little bit steered by what
The governor does.
what the governor does, right? I don't know when you're thinking of having the next meeting, but and it shouldn't be just our job to be reactive. I mean, if we can be creative policy wise, the Labor Committee did have a bill in the last session to create a behavioral health task force to really bring in legislators and providers and law enforcement and all to really discuss. And that bill ended up not passing. And there was there were enough legislators that said, oh, well, we don't like task forces. We should just do it in our committees. Well, so we're kind of the mini version of a behavioral health task force. We just have to think 3 times as hard for lack of more people. But, since Senator Schiffer's days, I mean, since we're looking at the same problems that we had in 2005, 2006, if you go back to the task force then. And so hopefully we can just be creative enough to really, not just respond to the governor, but just try to think conceptually. But I don't really have an answer for that right now.
Okay. So just one thing that I would like to see a follow-up from staff on for future consideration. And I'm going to turn my attention away from the criminal system. But what we found out when we were working on the retirement center is there's nurses over there in the basin that don't want to work for state government for 25 years and walk out with a pension. One said, my husband's a cop. I don't need all that crap. Quit giving me 25 bucks with a pension. Give me 35 bucks and I'll just work per diem. That's the term of art in healthcare. It's called just working per diem. When we need you, we call you in. If we don't need you, we don't call you in. So when the census is full, you bring them in and pay them a higher daily rate or hourly rate than full-time on-staff people. And what was happening in the retirement center is those nurses would leave, they'd go to work for an agency, and the state would hire them back at $70 an hour through the agency because they didn't want to change the rules at A&I. And so we were working with Lisa Oswald. This is for Elizabeth and John, Lisa Oswald. And she was trying, and this is for the veterans home. This is for the state hospital. It's a model of the 1950s. You come on board, we hand you a pension, you retire in 35 or 25 or 20 years, you get a gold watch. And there's a lot of people don't want to work that way. And so we were trying to get A&I to just say, create a status called per diem. Let us pay nurses 35 bucks an hour or whatever it is that don't want to work full time for the state. And damn, it was like pulling teeth. I don't know if it's done yet. I don't understand what the resistance to A&I was, but I'd like a presentation on where we are on that. If we've created a status of employees that are just called per diem contract, you know, they're not contract, they're just per diem, they're non-benefited. And you can see, you know, A&I, it's state government, they don't want to do that, but I think it's important, particularly in healthcare. So Sue, you remember in the 90s when the government really started reforming all the payment models, and I had nurses on staff full-time, pharmacists on staff full-time, had to call them in and say, you're full-time and you're full-time, the rest of you are all working per diem. Every hospital had to do it, every nursing agency, every home care agency. The government's just not going to pay for people to be on staff full-time when the census isn't full, except when it's state government running the institution or paying the bill. So I'd like staff to find out where we are on that.
Mr. Chairman,
Yes.
we will certainly look into all these things. Before the committee gets much farther, I just wanted to remind them that public comment was not taken on the Department of Health questions update topic, and we have a number of people in the waiting room who indicated their wish to provide such comment, including Representative Sweeney.
Oh, okay. Well, let's bring Representative Sweeney in right away. Heck, I didn't realize we took comment on an update on questions, but okay, go ahead. Representative Sweeney. Welcome.
Hey, Pat.
See if I can.
You're on. We can hear you. Oh, you just muted yourself again. Okay, you're on.
So I need to mute. I think I need to mute my. Oh, all right. So can you still hear me?
Yes.
Okay. So sorry to. I just joined a half hour, 40 minutes ago from the State Building Commission meeting. So I apologize for that. In testimony that you've heard from Mr. Craig, when it was directly in regards to Department of Corrections, was there any thought process in adding to the agenda for next time or from Department of Health or Department of Corrections for your future agenda, anything more with Department of Corrections?
I don't know that I can answer that. Based on what we heard from Mr. Craig, are we going to add anything more to the future agenda regarding Department of Corrections? Yes, I think we've asked for some follow-up information.
Okay.
Representative Larson.
Yeah, Mr. Chairman, I think the direction we were really trying to get to today, and that we'll have to continue in the future, Representative Sweeney, are how we provide mental health and substance abuse, excuse me, services to those people under the jurisdiction of the Department of Corrections, but who are out on parole or whatever, back in the community. Should that be under the Department of Corrections, or should that then be shifted over to the Department of Health in a new system or an existing system, such as the community mental health providers? And how would that look? And so I think one of the things that we've talked about is establishing priorities for the community mental health providers, and who should that be, and why should they be? And I think at least there is some strong inclinations to say that would be those people that we referenced who are under the jurisdiction of the Department of Corrections, to make sure that we help them control or overcome those addictions and prevent recidivism.
And to that, I would add, Representative Larson, people who are post-arrest, pre-disposition, post-disposition, pre-sentencing, and then post-sentencing, whatever their status is, whether it's, you know, waiting to go to prison or halfway house, drug treatment, probation, parole. So it's not just after they've been released from the poke.
And it, Mr. Chairman, if I could follow up, I would just caution that WAMSAC members aren't necessarily, and our community health providers, such as our centers, aren't the only possible competitors, you know, in that there are private foundations and non-members that wouldn't be associated necessarily with our like Central Wyoming Counseling Center or any of the other providers. And hopefully you'll consider that also in future discussions.
I guess I'd say this about that, and then I'll let Representative Larson go. I get it. I just don't think we have the time for that right now. If we're going to get anything done, if we're going to winnow them down and say you don't take in non-priority populations, we need to integrate more tightly into the correction system. I don't think we have time to go out to bid to create a whole new companion system to run beside the system we have. 2-3 years down the road, maybe we circle back, but this is what we got, and I just don't see us now. You know, the committee may take a different direction, but you know, we have enough issues in the system in terms of coordination and continuity of care without adding new players or additional players into the system. That's just my view. Representative Larson.
Thanks, Representative Sweeney. Really what we've been trying to talk about here is the current funding of mental health as it exists now. And that really doesn't contemplate bringing additional people into that system. We're trying to figure out how we reduce those costs. Well, it could, if we say we don't think the community mental health providers are working, that system is broke, then we could start from scratch. I don't know that this committee is at that point of making that decision, but in fairness to the discussion, sure, that could be one of the options, start completely over again. And then we could just send it out on a bid basis every year and say, this is what is expected. But I think initially the conversation is how do we take that systems that's in place and better use who do we serve, and with the reductions that we see in funding with the money that we have.
Mr. Chairman, so I'm not trying to reinvent the wheel, and no, I don't think you go back out to bid. I'm more in line with Senator Richard's comments that open markets, free markets, you know, with community providers already in place, that they may not be associated. They may be out on their own, not necessarily a member represented within your community mental health centers. But and I think there's efficiencies also that we can look at with licensing also. But again, Senator Bouchard has done more work on this than I, and we've tried to work on those issues, but have received a lot of opposition. So, but anyway, I appreciate the comments and the time, and appreciate the committee's good work. And if there's anything I can do, I'm one of the sole people in the Republican Party that believes Medicaid expansion might work right now. So, and I understand Senator Schuler brought some issues up, and you're going to be looking at that at other states that have expanded. And the waivers, I think we can build on the waivers. So is my belief. But thank you, Mr. Chairman.
Representative Sweeney, thanks for rolling off of one committee right into another.
So, and
Your
I
time is-
after that committee, and I feel your frustration with A&I because I'm worried about getting the CARES Act money spent. And I was just talking air conditioning filters. Holy cow. So anyway, appreciate your time. Thank you.
All right, thank you. Who else do we have in the waiting room, John?
We have Miss Somerville, Mr. Demple, and Miss Foland.
Okay, let's take Miss Foland. Hello.
Oh,
You're on.
oh, thank you, Mr. Chairman. I would like to just say to the committee, thank you for your diligence on these very difficult topics. I have watched up close and personal and from afar your work, Senator Kinski, for the last several years as chair, and obviously Chair Wilson. You guys have been absolutely awesome. I did take an opportunity. The Kaiser Foundation does provide that information for Senator Schuler's and Representative Wilson's questions about the expansions. There are multiple types of waivers that I do believe Wyoming would be absolutely perfectly set for at making application to CMS. And I have had the opportunity to work in 2 of the states that did not expand and did enhance the waivers, Kansas and Texas. And I think there is a world of information that we can build on and provide those services to our fellow neighbors in our state. And for that, I stand with it for any questions.
So if you have you forwarded that to us that we can get it distributed out to the committee?
I have not, but I will as soon as I am off this call.
So if you have Elizabeth Martineau or John Brody's address, that'd be the best to send. They'll see that we get it. Thank you for that.
Absolutely.
Greatly appreciated. Who was next, John?
Mr. Chairman, up to you, but we have Mr. Demple and Ms. Somerville.
Well, let's take Andy, and then we'll finish Paul off.
Mr. Chairman. Thank you. Andy Somerville representing WAMSAC. I just had a couple of quick comments, and I will stand between you and an early end to the meeting, or early-ish. I just wanted to reiterate what Representative Wilson said in terms of moving pieces in the system. I am always very supportive as of my providers about thinking outside of the box, and we're willing to consider any system that gets mental health and substance abuse services out. But her comments about fixed cost and what potentially moving a large section like the criminal justice system clients out of our current community mental health system, it would most certainly collapse the small and medium-sized centers and probably very seriously affect the large centers as well. Because as I explained in my last meeting, the system and the funding system that supports community mental health centers is really a giant puzzle. And everything is built, whether it's city and county, state funding. State funding is the largest piece for a lot of our centers in terms of revenue. So again, we just want to be careful on how we move the system going forward. So I'd encourage everybody to think about that a little bit. And then the other piece, as we're thinking, is keeping in mind that rural differential. It does cost probably more to operate a center in a more rural part of the state where there's a smaller population. That's a conversation I've brought to the attention of Deputy Director Johansson. for our work group conversations going forward is how do you balance funding a center in the southeast corner of the state versus maybe the central part of the state where we don't have that many people. And then last, I just want to add on to the previous speakers on the Medicaid waiver. I am far from an expert. I am learning more every day, but I would recommend to the committee that you get data on both the 1115 waiver as well as the HCBS, which is the Home and Community-Based Services waiver. And with that, Mr. Chairman, I'd be happy to stand for any questions.
Any questions from Ms. Summers? Give it about 2 minutes. Nothing? All right, Andy, you're off the hook. So appreciate you being here.
Thank you very much. Of course. Thank you.
Paul Dimple. Go ahead, Paul, unmute yourself and you're ready to go.
Okay, sorry, I got caught off guard with the delay. Mr. Chairman, members of the committee, I just got a couple of things. There were some questions I wanted. Representative Wilson had asked, what percentage of folks, adults 18 to 64 were on Medicaid. So I ran some quick data, and this is just Northern because I don't have anybody else's data. Overall, 12% of the folks we see have Medicaid. 16% of the females we see have Medicaid and 9% of the males have Medicaid. So that's our current breakdown of that. The other thing, a lot of times people interchange Medicaid and Medicare. Medicaid in our world is a good payer. They allow us to provide a lot of services. Medicare, on the other hand, has limitations, and because of the LCSW limitation, if I got a LPC in Crook County, we just basically get no dollars for any Medicare. And I know the national folks have been trying to work on that for some time. In terms of the community mental health system and the idea of private providers versus not, there's a distinct difference between private providers and the community mental health system. And that distinct difference is it's not just providing therapy. It's a wide array of services, especially on the very seriously ill one. But most importantly, we're all CARF accredited. Everybody that contracts with the state are CARF accredited. They come every 3 years. They comb through everything with a couple of thousand different criteria. They look at all our records. They're reviewed extensively. Not only do we get reviewed extensively there, we have internal quality control as well that's required for us to pull charts and independently look at them. The therapist doesn't look at their own chart. Somebody else does, and take remedial action if we find some issues there. Additionally, and it's been less so because of, I think, the constraints of staffing and everything going on, but historically the state has come in once a year to our shops, look through everything. So the community mental health center systems are highly structured, highly organized, and have tons of oversight. So I think those were probably the things that I wanted to highlight. Looks like
no, Mr. Chairman had Chairman Kinski had a meeting at 3 o'clock and he had to leave, so we'll wind it up. So Paul, is there anything else that it's Representative Wilson, please.
Thank you, Mr. Chairman. Paul, I do have one thing. So thanks for the data on the percentage of your patients who are Medicaid. And so I'm asking you something now to kind of off the hip. I talked about if the person were disabled and then they could get on Medicare and thus on Medicaid. Do you have sort of social worker types that try to get people onto disability and then onto Medicaid, or so the people that you have who are Medicaid, are they typically on Medicaid because they're disabled or for some other reason?
Mr. Chairman.
Please, Paul.
Mr. Chairman and Representative Wilson, in my experience, and I'd have to go do some digging, so I'm just going to speak off the cuff. The primary people we have that we see chronically are on for disability. That's what they're on for. But I would have to do some more digging to give a definitive answer. Second thing, there is a program called SOAR, S-O-R-A. And the SOAR program is really designed to get people trained up and to fill out the forms correctly and work with the person and do everything they can to ensure as best you can somebody's going to get on Medicaid or on disability. It's really disability that they're getting on. And it's a very time-intensive process. And the data says the people that have somebody providing SOAR have more success and get on quicker. The flip side of that is, especially in the current environment, in order for me to have somebody who would just do SOAR because it's so time intensive, I would have to take a service provider offline. But we had one, I think 2 different people trained with SOAR. I think some other centers are doing it. Nationally, it seems to work. So I think it'd be something for the state to look at. The other thing I'll tell you too is we check everybody every time they come in against instantly, are they on Medicaid? Or we're very aggressive about that. So.
Any other questions, Representative Wilson? Committee, I think we just received also a map of those states that have expanded Medicaid. Might just tuck that away for reference in the future or refer to it. Thank you, Elizabeth, for doing that. Paul, anything else you've got for us, or wind things up?
Mr. Chairman, the community mental health centers are looking forward to ongoing discussions with the Department of Health to come together to tackle this problem. And I think with the committee's direction, I think we'll be able to find a path forward, whatever it is.
Okay. John, do we have anybody else that would like to make public comment?
No, Mr. Chairman.
So in conclusion, committee members, anybody that would like to make a final comment or questions to any of those people that are presented or to staff? Okay. John, maybe if I could just ask you to maybe you and Elizabeth put a summary together of all of the things that we've asked you to do. That might be volumes. It was a boatload, and then maybe Senator Kinski and I can go over those with you, and we'll sort out how we need to proceed forward. I would just remind the committee too that so thus far we've talked about community mental health. Today we brought in the prison population, and then the one other component that is out there is that DFS community and I know that Chairman Wilson, you guys are going to be talking some about that in one of your next Labor and Health Committee meetings. Maybe we can get together and kind of see what this committee can be doing to in preparation for that. And Representative Barlow has also been engaged in that. I know we've had multiple conversations, the 3 of us, over the last year on some of the silos. When we talk about silos, man, there they are. And so we'll be bringing that in some form back to this committee to have a discussion and understand and see if we need to do anything there. I would also, just in closing, share to the committee that this committee, the intent of this committee is we need to look and see and make recommendations back on where statutes should be changed, how this should look differently, look at this whole system and just like any other select committee, and let's kind of come up with a format, and then we'll bring that back to the 2 committees, Labor and Appropriations, to move any legislation forward that we need to. But we've been doing the work here and focused on that, and so be ready to continue that. And with that, John and Elizabeth, is there anything else that you have? I know I've asked you that once, final time.
No, Mr. Chairman, we will prepare the committee's summary and provide it to the chairman
Okay.
probably this week.
That'd be great. Thank you. With that, have a good rest of the afternoon. Thank you, everybody, for the effort. We extend our appreciation to those that participated today, both in presentations and in public comment. Thank you. Have a good rest of the day.